Okay, let's start. Okay, we will first finish the pharmacology block. Okay, there are 51 questions. After that, I think so we need to do 11 more questions. Okay, then the pharmacology is finished, and then we are left with anatomy, physiology, embryology. Okay, which of the following changes are likely to occur in this patient following octreotide treatment in this patient? Okay, first try to diagnose the patient.
We can't hear you, by the way. Can you unmute yourself?
Mm, I think so. Everyone can
Yeah.
hear me.
Yes.
Yes, I can hear.
Yes, we can hear you.
A 50-year-old man comes to the office following transsphenoidal resection of growth hormones treating pituitary adenoma. Okay, the patient has a pituitary adenoma. Okay, the patient was diagnosed with acromegaly. Okay, MRI of the pituitary shows a 14 millimeter cellular mass pressing on the optic chiasma and it's extending into the right cavernous sinus. The surgeon was able to only partially resect the pituitary mass because of the extension into the right cavernous sinus. Medical therapy for acromegaly with octreotide is planned. Which of the following changes are likely to occur following octreotide treatment in this patient? Okay, so octreotide how does octreotide affect the growth hormone? How does the octreotide
It's
affect the
inhibitor
I
growth
of
hormone?
think it decreases it.
inhibitor.
It decreases. Okay, if it decreases the growth hormone, what will happen to the adenoma size?
Decrease.
Decrease.
The adenoma size will also going to be decrease. Do not treat with octreotide. It is a somatostatin analog. Okay, octreotide. That's a somatostatin analog, which is used for the treatment of acromegaly. Okay, and it is going to decrease the pituitary adenoma size, right? B,
Yes.
C, D, E, all are eliminated. What will happen to the growth hormone?
Decrease.
Decreased as well because it's
Decrease.
decreasing
Yeah.
it.
What will happen to the IGF-1 levels?
Also decrease.
All of them are going to decrease. Very good.
How the adenoma size will decrease?
Because the cells of the adenoma which are producing the growth hormone are now going to atrophy. Okay, they are going to atrophy because they are no longer producing the growth hormone. That's why the size is also going to be decreased. Okay, because that's the it is a hormone producing pituitary adenoma. Okay, and the hormone that this adenoma is producing is growth hormone. Okay. Okay. If this patient weight loss is due to new medication, which of the following agent is most likely responsible? Okay. Okay. You have to tell which one of these drugs can cause weight loss.
C.
Okay. Okay. First read the options.
DLP.
So yeah. So he is asking which one of the anti-diabetic drug can cause the weight loss. Okay. SGLT2 inhibitors can cause. Okay. Which drugs can cause weight loss?
One is the metformin and other is the GLP-1 analog.
Metformin.
And
Metformin,
also the SG2 inhibitors also can cause the weight loss.
SGLT2
Yeah.
inhibitors, GLP-1 analog,
Yes. And
agonists.
metformin also. These three drugs are weight losing drugs.
Metformin is weight neutral or weight loss?
Weight
Little
loss.
bit weight loss. Little bit.
Written
Not
is
as
Weight
much.
loss.
PCSK4
Becoming
inhibitor is
bones.
weight neutral, but metformin is weight loss.
has less effect on weight.
It is weight loss. Weight loss. Okay. Okay, Ozempic. Ozempic is which drug? GLP-1
GLP-1.
GLP-1
GLP-1.
is
An
injectable, yes.
analog.
Okay. Sulfonylurea. GLP-1 agonist. The weight neutral. They have mentioned the metformin in weight neutral category here. I don't know why, because in first aid it is clearly mentioned that Ozempic is weight loss drug. But
So
in first,
we need to choose the like which is the most best choice in that. So I think yeah, GLP-1 was the one.
yes, but I think so. Metformin is not even in the options.
Yeah, I
Metformin is not even the
talked one of diabetologist. He told that only 2 gram of metformin decrease the weight.
okay.
Not high doses, yes.
Okay, when you give metformin in very large doses, then it can decrease the weight. Okay, that's a good explanation why it
So
is
there's
weight neutral.
another explanation too. With metformin, you have to give some kind of semaglutide or something or a terapeptide like Monjaro or Zepbound, which helps weight loss to a maximum. But alone weight loss won't be happening with metformin. A very high dose would be given, and which would lead to hypoglycemia, hypoglycemic shock भी हो सकते हैं. So metformin is not exactly weight losing according to modern medicine. It is a weight neutral mostly.
Yes. So even in the first stage, it is written weight neutral medication. Okay. Activation of the receptor would most likely result in which of the following metabolic changes? Okay. 50-year-old woman enrolled in a clinical trial. The study drug activates peroxisome proliferator activated receptor gamma, a nuclear receptor, and transcription factor.
See?
Okay, so do you people know which anti-diabetic receptor medication activates this receptor?
Glitazone.
Glitazone. PARP. जिसको कहते हैं.
PPR gamma. Okay, the peroxisomal proliferator activator receptor gamma. That receptor is activated by thiazolidine zone, which is a pioglitazone. Okay.
Sir, if you don't mind, can we just also go with the adverse effect, just one line with the first aid because it seems high yield.
Okay. Okay. Which one? Down regulation of adiponectin. Option number B is not the function of a pioglitazone. Increased insulin release is a function of which? In a option number D would be the right answer for what drug?
Sulfonylurea.
Sulfonylurea.
Sulfonylurea. Sulfonylureas. Okay. Leptin, there is no effect. Which one is going to be the right answer here?
A. Decreased insulin resistance because it increased the insulin sensitivity.
Okay, so it comes so it acts in the same manner as the metformin.
Metformin.
There are two drugs which increases the insulin sensitivity. One is pioglitazone and the other is metformin. And what is we no longer use pioglitazone. Why? What is the major side effect of pioglitazone?
Edema.
Edema, and it is a
Heart failure.
Heart failure.
Cardiovascular.
okay,
Heart failure.
Okay, that's the main reason we no longer use this drug. Okay, heart failure. Okay, so it increases the insulin sensitivity. The other drug which also increases the insulin sensitivity is metformin. Okay, it will decrease the insulin resistance and will increase the ability of the cells to respond to the insulin. Okay,
I just have a quick question.
yes.
I work in the pharmacy in a USA based pharmacy. Some patients are still on pioglitazone. Is it completely out of the market or some people do use it?
I think so. If you are in the US and some people are still using it,
Yeah, I
I
have
think
seen it.
yeah. So it is not still not out of the market, but now most of the doctor do not use this drug. Okay, because now we have much better drugs than that. Okay, and this drug has much more side effects. This drug causes weight gain. This drug causes a heart failure, increased risk of edema. That's why we do not no longer use that drug. Okay, mostly we use SGLT2 inhibitors, Ozempic, Monjaro,
Mm-hmm.
Wegovy, but
Yeah,
no
yeah, I've seen.
metformin. But we no longer use this drug.
Okay. All right. Thank you.
Okay, let's move on to the next one. Which of the following is the most likely cause of this patient's current condition? Okay. This question. 22-year-old woman comes to the emergency department due to fatigue and sore throat. Okay, fatigue and sore throat. The throat discomfort has caused her to unable to breathe and drink without significant pain. Okay, acetaminophen improves the pain slightly, but her oral intake has been poor. The patient recently started taking anti-thyroid drugs for the Graves' disease. Okay, she has no she has no other medical condition, does not use tobacco, alcohol. Weight is decreased to 67, decreased from a week ago. Temperature is elevated. Okay. Physical examination shows erythematous pharynx with shallow mucosal ulceration and a normal sized thyroid. Mucous membranes, okay. Does acute adrenal insufficiency can explain the erythematous pharynx and the sore throat and the high temperature in this patient? Acute adrenal insufficiency?
No.
No. Okay. Excessive thyroid suppression, hypothyroidism. Can hypothyroidism
No.
explain this? Okay. No.
No.
He still has some symptoms.
Yes. Still
Okay.
tachycardia.
Thyroid hormone induced severe hypermetabolism. Can hyperthyroidism can explain these symptoms?
No.
Option
No,
number
it's when there is thyroid storm, but it's not picture of thyroid storm.
yeah. Even in thyroid storm, you do not have a sore throat.
Ulcers.
Okay,
Yes.
and ulcerations, and
Mhm.
that cannot be explained by a thyroid storm. Okay. Okay, virus induced lymphocyte destruction. In option number E, he is talking about what diagnosis?
Decovariant, I think.
Decovariant thyroiditis.
Thyroiditis.
Yeah, he
Yeah.
is talking about decovariant thyroiditis. But in our patient, there is no, the thyroid is not tender. Okay, and in decovariant, we see hypothyroidism or hyper.
Hyper.
Hypo.
Just hyper.
Oh,
Slightly hyper, then hypo.
First
Hypo.
hyper,
Yeah.
then hypo.
I
Hypothyroid.
think it's hyper first before
Hyper
hyper.
first, then hypo later,
yes.
right? But that can also the findings which are present in this patient are also not consistent with where decovariant thyroiditis, right? Okay. Drug induced granulocyte destruction. What drugs that this
Yes.
patient is taking?
Anti-thyroid drugs.
Methanol.
Methimazole.
Methimazole and
Methimazole.
PTU
Okay.
both.
PTU, yeah.
And what are the side effects of these drugs?
Agranulocytosis.
And if the
Skin rash.
patient is agranulocytosis, that means that its neutrophils, basophils, and eosinophils are less, right? And then there is much more highly much more chances of getting infected, right? Because the patient's immunity has decreased, right? The patient becomes neutropenic, right? So that can
Yes.
explain the sore throat and the ulcerations which we are seeing in this patient, and the erythematous pharynx and the elevated temperature, right? All the findings in this patient can be explained by the agranulocytosis, right? So,
Correct.
so B will be the right answer. Drug-induced neutropenia, agranulocytosis. Okay. So neutropenia, okay, orange ulcer, fevers with, okay. It will be discontinued and usually resolves the neutropenia within 1 to 3 weeks. Okay. Their side effects. Okay. Next one. Which of the following is expected as an immediate result of this treatment? Okay. Which treatment we have started? Okay. This drug here we have started, and he is asking which is going to be the okay. So he is asking us about the mechanism of action. How does the evolocumab a drug works? Okay, option number A, decreased hepatocyte cholesterol synthesis. Which drug has this mechanism of action?
Statin.
Statins. And evolocumab is not statin, right?
Monoclonal antibodies.
Decreased intestinal cholesterol absorption.
Cholestyramine.
No.
Cholestyramine, cholesterol.
Decrease intestinal cholesterol absorption.
Like enterohepatic.
Ezetimibe. Okay. 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 Now we are left with C, D, and E. Okay. Stimulation of low density lipoprotein receptor transcription, increase the XLDL. Okay. There is no drug like that. Okay. Which one is the mechanism of action of evolocumab? C, D, or E?
It decreases the LDL receptor number.
Decreases the. Okay.
I mean, it inhibits a protein which increases number of LDL receptors. So
The cholesterol formation, ezetimibe. Okay. And PCSK9 inhibitors.
yes, PCSK9 inhibitor, exactly. It decreases this number.
It's
It inhibits
inactivation
this
of the
protein.
increased removal of the LDL from the bloodstream. Evolocumab, which is mentioned in the question, it will inactivate the LDL receptor degradation. Okay, by inactivating the LDL receptor degradation, we are going to see increased LDL receptor on the hepatocytes. And when there are increased LDL receptor on the hepatocyte will be able to clear out the LDL from the blood much more easily. Okay. So the right answer is going to be. So which one is going to be the right answer?
C.
C. Decreased LDL receptor
LDL receptor.
degradation. Okay. Okay. Inactivation of LDL receptor degradation. Evolocumab. Okay. PCSK9 inhibitors. Okay. Which of the following drug concerns shown in the is most likely be to obtained after subcutaneous injection of the insulin. Read the question. Subcutaneous insulin is fast is that insulin rapid acting insulin, or is that insulin fast, or is that insulin a regular insulin, or is that insulin is a long acting insulin?
It's a regular short acting.
So remember, in this our patient is suffering from what? Diabetic ketoacidosis here, right? And for the treatment of diabetic ketoacidosis, we always use regular insulin.
Regular.
Okay. And in the question, he has mentioned that we are going for a subcutaneous injection of the insulin, which is most likely be regular insulin. Okay. And we
So the
know,
option is B.
know which curve is of a regular insulin. This one. This is a regular insulin curve. This is NPS, tetramer, glargine, and digoxin. Okay. Which curve would be the right answer?
B.
Number B. Remember, for diabetic ketoacidosis, when it develops in a type 1 diabetes mellitus patient, we will use regular insulin. Okay. Next. Okay. Which was the
Sir,
first?
can we, sorry, sir, can we just quickly review those curves? Just like which will be the the short, like the fast and NPH.
The first one is going to be the one which whose half-life is going to be the shortest, right? So curve number A is for fast
Rapid
acting.
acting.
Rapid
Aspartate.
acting.
Aspartate.
Nitroglycerin. The green curve. The green curve is for what? If the B curve
NPH.
is for regular, the
Intermediate.
intermediate.
NPH.
And the
Intermediate.
purple curve, and the purple curve,
Glargine.
no, glargine is for is going to be E.
I think it's determined. Insulin
Determined.
Determined.
D for
Determined.
Determine.
D for
D
determined.
Determined.
D for determined. Yes,
Determined.
determined, then glargine. Okay.
Mm.
Which of the following drug most likely started in this patient? Started on a medication that inhibits the cholesterol absorption at the brush border. That inhibits the cholesterol absorption from the brush border.
Ezetimibe. Yeah, ezetimibe. B. Yeah.
What is the mechanism of action of PCSK9 inhibitor?
Inhibit the degradation of LDL receptors.
Receptor. It decreases the degradation of. Okay.
Of LDL receptors.
LDL receptor.
Fibrates acts on what receptor? Do you know? Which anti-diabetic medication receptor acts on the same receptor like the fibrates?
PPAR gamma.
Yeah, they act on PPAR gamma, which is the same receptor of pioglitazone. Okay. Okay, and option number A. Option. How does option? What is the mechanism of action of option number A? Option number A belongs to what a class of drugs?
Bile acid resins.
Bile acids, it will bind the bile salts in the intestine and will going to decrease their absorption. Okay. We need to know which is going to decrease the cholesterol absorption. Okay.
Huh? Yeah. What? You doing something? Uh-oh.
Fatima, please mute. Thank you.
Okay, and in the question, is it amide? Prevents cholesterol absorption at the small intestinal brush border. Name of the drug? Ezetimibe. And in the question, he is asking which drug inhibits the cholesterol absorption at the brush border. Okay, ezetimibe. Once the patient has been medically stabilized, which of the following medication will be most helpful in preventing recurrences of this condition? Okay. Since
It can be niacin. Considering the patient is an kind of alcoholic. Oh, per week, okay.
to the emergency department of pain and vomiting. These symptoms begin acutely. What is the diagnosis in this patient? 22-year-old man, abdominal pain, vomiting, begins acutely 24 hours ago with nausea and decreased appetite. The patient drinks 3 to 4 beers a week. 3 to 4 beers a week, and
Acute
BMI is 37.
pancreatitis.
And the patient has moderate epigastric tenderness with decreased bowel sounds. What is the diagnosis here?
Acute pancreatitis.
Acute
And,
pancreatitis.
and why the patient has acute pancreatitis?
Is alcoholic and
Triglyceride.
obese.
Alcoholic.
Obese. Yes. BMI 37.
Base. BMI is 37.
Yes, the main cause is
And
beers or
triglyceride.
the main cause is triglyceride.
Triglycerides. Yes. He's got
Triglyceride.
pancreatitis.
He only drinks 3 to 4 beers a week, not in a single day, in a week. Okay, so but his triglyceride concentration is 1500. Okay, and the normal is less than 200. Okay, hypertriglyceridemia can cause acute pancreatitis.
Yes.
Right. Remember that type 1 hyperlipidemia question we saw. In type 1, there is hypertriglyceridemia, and what is the main side effects, main complication we see in familial hyperlipidemia type 1? Acute pancreatitis.
Pancreatitis, yeah.
Okay.
Mm-hmm.
Okay. So now we have to find a medication which is going to reduce, which have the most highest effect on the triglyceride levels. Okay. Which drug has which anti hyperlipidemia drug has the highest effect on the
D.
decrease of the
Yes.
triglyceride?
Phenofibrate. They are the highest for
Fibrates.
triglycerides.
Remember, see the 3 arrows here.
Fibrates, right? Fibrates work fine.
Yes, fibrates has the
Fibrates then
highest.
goes to omega acid.
Yes.
On an order, it goes from fibrates and omega acids, omega-3 fatty acids. So it's fibrates.
Okay. The highest decrease is can be achieved by fibrates. Okay. What would be the answer? Fibrates. Okay. What is the mechanism of action of cholestyramine?
It is a
Bile acid resin.
Stimulating agent.
It is a bile acid binding resin. It will inhibit the absorption of bile acids in the gastrointestinal tract. Okay, subsequently interfering with the enterohepatic bile acid circulation. Okay, okay. The weight loss induced by this medication is caused by which of the following mechanism? Okay, so it is a weight loss drug. Let's see what drug it is. 34-year-old woman. Due to inability to lose weight despite diet and exercise, she reports that she gained a significant amount of weight after she stopped smoking 4 years ago. Has tried several commercial weight loss diet programs in the last year without success. She wants to lose at least 4.5 kgs. Okay, before she gets married. Blood pressure is 122 by 80
Sir,
pm.
A cannot be the option because delayed gastric emptying helps in weight loss, so that's not an option.
Okay, the physician prescribes a short course of oral phentermine for weight loss. Delayed gastric emptying is the mechanism of action of what weight loss medication?
GLP-1 agonist.
GLP-1 agonist
GLP-1.
medication. But
Yeah.
in the question we are discussing phentermine.
Yes, fantastic.
Okay. Lipase inhibition. Which medication? Lipase inhibition in the intestinal human.
Phentermine actually reduces the appetite itself.
Holy state.
The CNS
Orlistat.
stimulating drug, right?
Holy state.
Yes, Orlistat has the mechanism of action of lipase inhibition.
Inhibition, yes.
Okay. And but in the question, but we are talking about phentermine. Okay.
Yes.
Okay. Okay. Opioid antagonist drug can be used for weight loss.
Yes, naltrexone, but no, this just used for the constipation, so it's increase the motility of the GIT. There is naloxone using IV, and naltrexone is using orally. It's only for those patients who develop constipation by using the opioids.
Okay, what is the mechanism of action of phentermine?
Phentermine stimulates the CNS to suppress the appetite.
Increase norepinephrine release in the central nervous system.
Phentermine is written.
Sir, actually it is norepinephrine. Norepinephrine. It helps by increasing certain transmitters in brain, especially in hypothalamus. That causes that regulates the appetite section. You can look it there.
Yes. Isn't it right? Yeah.
I think so it is written in the general pharmacology, right?
Yep.
Not general, but in GIT, sir. I think it's in GIT too.
Can you tell me the page number?
Give me a moment.
It is written in the Orlistat inhibits the pancreatic lipase. Okay, Orlistat. Okay.
What's the page number?
The page number is 407.
Okay.
Okay. But I'm trying to find where it is written about the phentermine. I think phentermine is written in the general pharmacology. Okay, reduce presynaptic reuptake of serotonin. That is the mechanism of action of SSRIs.
Sir, I think I didn't read this in U World. I didn't read this here. I read it somewhere in RX question. And the
No,
answer
it's in psychiatric. It's in psychiatric option unit. I think so.
I so read it in RX question bank Wix somewhere, but the option is definitely because of non-epinephrine stimulation.
Yes, option number D is for the SSRIs.
SSRIs. Definitely we can
And
rule it out.
Number
yeah, it
E
is
is the
not.
right answer. Release of norepinephrine.
Yeah, the release of norepinephrine is the right answer. Sympathetoamphetamine, diethylpropionate, both of are stimulants, high rate of weight
Yes.
regain.
Yeah.
Orally stat is a lipase inhibitor. Bupropion and naltrexone is a they
Smart.
are also, yes, they can also be used for weight loss. Okay.
It's basically increase the level of norepinephrine.
So can we go back to the last question for 1 minute? Uh,
Yes.
since we all are doctors, I have a small real query. So the patient has mentioned that she has been gaining weight after cessation of smoking, right? In the question.
In addition to encourage continued efforts at a lifestyle change, the physician describes a short course of oral phentermine for weight loss. Okay. So what is
Sir,
your question?
as of a few of our doctors' researches, we know that when a patient smokes, what happens is the smoke settles in some of the fat cells. So when a patient tries to burn weight, the bad effects come out when the fat cells are actually burning. Uh, is it actually true?
Can you again repeat your question? Sorry.
I read it, sir. Like there was this blog where few of the doctors who are doing research on cessation smoking and weight gain, weight loss, some of them were saying when a patient, for example, there's a patient of yours who is smoking for like 1 or 2 years, and after quitting smoking and they started gaining weight, so they started working out. They're losing weight now. But when they're losing weight, first things first, they said it is very difficult to lose weight. Secondly, when they are losing weight, the central obesity which is there, these obese cells are containing these chemicals, harmful toxins that are stored in the cells, like for further usage, like our vitamins, just like how our body stores vitamins and iron. And now when they're losing weight, these people are having this toxic effects apparently. Is that true?
I don't know. That. I haven't studied that, so and I do not know that if it is true or
Okay.
not.
Okay.
And I think so. You also do not need to know that for your USMLE platform. Okay. Okay, let's switching the patient therapy at this time is aimed at decreasing which of the following complication. Okay. A 26-year-old pregnant woman at 16 weeks gestation comes to the office for a prenatal follow-up. Okay. So we are changing it from PTU to methimazole. Okay. What is the side effect of of methimazole, which is not the side effect of PTU?
Hepatotoxicity.
Fetal skin abnormality.
Teratogen.
Yeah, we need to keep
Teratogen.
a check on liver.
Yes, methimazole is teratogen. That's why we does not use methimazole in the first trimester, right?
Yeah.
And both of the drugs are hepatotoxic. Okay, it's not like that only the PTU is hepatotoxic. Both of the drugs are hepatotoxic. Okay, but methimazole is the one which is teratogen. Okay, that's why in the first trimester we give PTU because in the first trimester there is the development of the organ, right?
P for pregnancy, P for PTU.
Yes, only for the first trimester. Okay. Usually,
Yes.
the first anti-thyroid drugs we give is always methimazole
And
because
PTU
of
also
the
have some concern in the third trimester. That's why, after first trimester, in second trimester, we can switch to the methimazole again.
okay. PTU used in the first trimester of pregnancy due to methimazole heterogeneity. Methimazole used in the second and third trimester of pregnancy due to risk of PTU-induced hepatotoxicity. Okay, so the main cause that we are changing it from the PTU to the methimazole is that the PTU is hepatotoxic in the second and third trimester, and
Yes.
methimazole is teratogen in the first trimester.
First trimester.
Okay, now read the question carefully and tell me
Beta skin
what would be the
abnormality.
answer here. A
A,
thyroid
sir.
treatment is changed from PTU to methimazole.
Yes.
Switching the patient therapy at this time
A,
is
Yeah.
sir.
aimed
The
at
answer is
decreasing which of the following complications?
fetal
Fetal
A.
skin
thyroid
Answer A.
abnormality.
agenesis.
Beta skin abnormality.
Yeah,
Skin
because of
abnormalities.
aplasia cutis.
Yeah, because
Again,
switch.
It's
read
C.
the
No, no,
question.
no. C,
C.
C.
It's C.
Maternal
Maternal
Yes.
hepatotoxicity.
hepatotoxicity.
Read the question
Maternal
carefully.
hepatotoxicity.
Can
C.
you kindly keep
Switching
quiet
the
at one on
patient
the one
Let's
question?
therapy
see.
at this time
One
is
out, please.
switching the therapy at this time is aimed at decreasing which of the following complication,
Maternal hepatotoxicity. Because
right?
PTU is associated with more liver damage. So in the first trimester, we are saving the neonate infant,
Yes.
and after that, we're saving the mother.
This statement is correct that the methimazole does cause is a teratogen in the first trimester, but this is not relevant in this question because he is not asking us about that. Okay, that's why I always say read the last line very carefully. Okay, there may be more than two to three options which are telling a correct statement, but that does not mean that is the right answer for our specific question.
Mm-hmm.
Okay,
Yes.
same in this question. Okay, in decrease changing from PTU to methimazole will aim at decreasing which of the following complication. Okay, it is not like changing from methimazole to PTU to methimazole. We have prevented what complication? If the question is that we have prevented what complication, then we can go with the fetal thyroid agenesis or okay. A,
Yes.
but fetal skin abnormalities as well. Okay, because methimazole causes aplasia cutis, which is the absence of the skin. Okay, then option A would make much more sense. Okay,
Yes. So
okay, but in this specific question, option number C would
is
be
more
the
the right
yes,
one. Yeah.
right. Okay, because of
Yes.
the PTU induced hepatotoxicity. Okay,
Yes.
what kind of changes, what kind of teratogenic effects does methimazole have?
Which is that?
What kind of teratogenic effects does methimazole have?
Absence of skin of the baby on the scalp.
Skin and scalp of the baby. It
Aplasia
causes
cutis.
aplasia cutis. Okay. Methimazole. Things it is something here. Methimazole. Aplasia cutis congenital.
Mm-hmm.
Typically on the scalp.
Yeah.
Okay. So if we was asking what condition we have prevented, then the option number A would make much more sense. Okay.
Okay.
Option number B will still does not make sense. Okay. It is
Okay.
either going to be option number A or option number C.
Yeah.
Okay. 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 So now I will make another block of the pharmacology. I think so 11 questions left for the pharmacology. Then we are going to start the anatomy, physio, and embryology. Okay.
Also, doc, please connect the charger because your mobile's battery is going down. Less than 10%, I think.
Okay, okay. Okay, let me create test. Pharmacology. Reproductive and miscellaneous. So after doing these questions, our pharmacology would be ended.
So how many questions did you say that he has?
11 questions, 11 more questions, then pharmacology will be ended. Then we are going to start the anatomy, physio, and
Okay.
embryology.
Okay. So that will be pharmacology for which and which?
Pharmacology only for the embryology, for the endocrinology. Okay.
Okay.
Okay. Which of the following is the most likely cause of this patient elevated blood pressure? Okay. Okay. The patient has easy bruisability, muscle weakness, smoked a pack of cigarettes daily for 30 years, hypertension, facial plethora, a centripetal distribution of body fat, a skin hyperpigmentation, bilateral peripheral edema, blood glucose is elevated, chest X-ray reveals a lung mass. What is the diagnosis here?
Small cell lung cancer.
And what is happening to that small cell lung cancer? What is happening due to that?
ACTH release.
And due to that increased ACTH, what is happening? Why the patient has easy bruisability, muscle weakness, facial plethora, Cushing syndrome.
Like Cushing's.
Yeah, the patient has Cushing syndrome, and the cause of that Cushing syndrome is increased ACTH, and the cause of that increased ACTH is a small cell lung cancer. Okay, that's why the chest X-ray reveals a lung mass. Okay, and we can and the patient has hyperpigmentation. That means that the ACTH is elevated. Okay, so the patient, and now he is asking why the patient has elevated blood pressure. Okay, why the patient has elevated blood pressure in this?
Due to high cortisol.
Due to
Because
high
of
cortisol.
elevated catechol.
We know that the cortisol is high in this patient. Okay, is the diagnosis is nephrogenic diabetes insipidus?
No.
No.
So option number E is not the right answer, right? Is the diagnosis is nephrotic syndrome?
No.
Okay. Is the diagnosis is pheochromocytoma? No.
No.
Option number B is also eliminated. Now we are left with option number A and C.
Option A.
Yeah, because patient has also high blood pressure.
Blood pressure.
Permissive effect of the steroids, cortisol, it increase the effect of the catecholamines.
So option number C would be the right answer for glomerulonephritis. Okay, and we know that in this patient, the main cause of the main pathology is Cushing syndrome. Okay, and we know that every glucocorticoid has an innate mineralocorticoid activity as well. Okay, every glucocorticoid has an innate mineralocorticoid activity as well. Okay, when that glucocorticoid is present in very large amounts, it will also going to cause mineralocorticoid receptor activation as well. Okay, other than that, it will also going to increase the adrenergic activity as well. Okay,
I see further cortisol.
okay, cortisol is going to increase the adrenergic sensitivity as well, and it is going to increase the stimulation of mineralocorticoid receptors. Okay, remember we have what is the name of this effect? How the cortisol increases the adrenergic activity?
Permissive effect.
Permissive effect. This effect is called permissive effect. Okay, okay. Which of the following condition in this patient is most likely to experience as a result of this therapy?
C.
Okay, 55-year-old woman is diagnosed with breast cancer and undergoes breast sparing mastectomy. The tumor margin did not show any invasion. Sentinel lymph node biopsy was negative for nodal metastasis. The tumor was estrogen positive, progesterone receptor hormone positive. Okay. The patient is started on one medication, tamoxifen. Okay. When she experiences hot flashes that come and go in waves and affect her sleep, she experiences hot flashes. Okay. So he is asking which of the following condition is this patient also likely to experience?
Option
Okay.
A.
Okay, let's see. Tamoxifen act as a agonist at what areas? And antagonist at what area? Actually, it is written in the
Breast.
reproductive.
At
Select.
uterus, it acts as an agonist, and at breast, it acts as an antagonist.
Okay.
Antagonist
Antagonist
at
is at
breast.
breast, partial
Partial.
agonist at uterus and bone. They are
Hmm.
estrogen receptor modulators. Okay. So if the patient has breast cancer and that breast cancer is estrogen receptor positive, and if you give that patient tamoxifen, we know that it is a estrogen receptor antagonist on the breast, then it will going to decrease the growth of the breast cancer if that cancer is estrogen positive. And what effect it is going to have uterus and on bone? We know that it is a agonist at the uterus and the bone.
Bone.
Okay, it's like giving estrogen to the uterus and the bone. Okay, if you give estrogen to the bone mass is going to increase or decrease?
Increase.
Increase.
Increase, right? Increase. So A is not the right answer here. Okay.
Okay.
Fibroadenoma of the breast cancer is going to decrease if it is hormone positive. Okay. Okay. What will option number C?
It seems correct.
Yeah,
Yes,
because it
it
acts
is
as
correct.
Increase.
a
Agonist.
Partial
agonist
agonist
on the
at uterus.
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 Okay, so it is going to cause endometrial hyperplasia.
Yeah.
Okay, tamoxifen. Okay,
Yes.
and there's one more that is relaxofene. Okay. Breast cancer, okay, endometrial hyperplasia and endometrial cancer. Okay. This is what? Endometrial hyperplasia and cancer as well. Increased risk in the tamoxifen. Okay, it is written in the endocrinology, in the reproductive. Which of the following pharmacotherapies most likely contribute to this patient current condition? Okay, see the option. Now see the condition. Comes to the emergency department due to left leg pain and swelling for the past 2 days. She had no trauma or fever. She has a history of hypertension, congestive heart failure, type 2 diabetes mellitus, and osteoporosis. She takes multiple medication. Okay, lungs are clear to auscultation. Heart sounds are normal without murmur. There is tenderness and edema of the lower extremity up to mid thigh. Wheels and occluding thrombus in the. So the patient has what?
DVT.
DVT. So the patient develops venous thrombosis, right? DVT. Okay, now we have to tell which one of these medication has a side effect of DVT. Does a option number C has a side effect of DVT?
No.
No, that is anti-diabetic.
Yes. Option number D, liraglutide.
No.
Option
No.
number A,
No.
liraglutide, Ozempic. Does that has a side effect of causing venous thrombosis?
No.
Okay. Okay. Thiazide diuretic. Option number B.
No. No.
Thiazide diuretic also does not cause venous thrombosis.
Mhm.
Spironolactone. Does that causes
No.
venous thrombosis?
No.
It's
No.
gynecomastia.
Okay.
Sir, I think E
It's the
option makes
Option
better
E.
sense
raloxifene.
because OCPs
Raloxifene.
help with DVT, right?
Yes. Raloxifene
Especially
and tamoxifen both. Raloxifene and tamoxifen both causes thromboembolic events. Okay. Both.
Okay.
Hot flashes. And what is the difference between tamoxifen and raloxifene? What is the major difference between these?
Low endometrial hyperplasia.
Effect on breast.
It
Sorry,
is
effect on uterus.
effect on uterus. The relaxophene is also an antagonist at the uterus. That's why it will not increase the chances of endometrial hyperplasia or cancer in the patient. Okay, and it is an agonist on the bone. Okay, but hot flashes, thromboembolic events, they are going to be the same in both tamoxifen and raloxifene. Okay. Okay. So what will be the answer here? Option number
Relaxifene.
E. Bravo.
Loxifene.
hot flashes. Remember, uterine sarcoma is also a it also a side effect of tamoxifen. Okay. So sometimes sarcoma, these are grapes-like structures which develop within the uterus. Okay, that can also develop due to tamoxifen only because tamoxifen is a agonist at the
Endometrium.
endometrium. Okay. Which are the following most consistent to be predominant bone effect with intermittent injections?
Parathyroid injection. Yes, the
Oh
parathyroid
yes,
has
I'm
the
in D.
intermediate
Yes,
at the intermittent
stimulation.
actions. It stimulates it acts as a bone agonistic effect.
Yes, exactly.
And with the continuous use, it has the uh,
Osteoclastic.
osteoclastic effect.
Mhm. Stimulation of osteoblast activity.
We can't hear you.
We can't hear you.
Sorry, sorry. Okay. Okay, so we have to see that in which option that there is increased bone activity. Option number C, there is also going to be increased bone formation because the osteoclasts are now degraded, and we know that osteoclasts are the cells which are involved in the degradation of the degradation of the bone. And option number B is also involved in the bone formation. Okay, now we have to choose between whether it is going to be C or D. Which one is going to be the right answer here?
D is answer, right answer.
In intermittent injection, D.
Yes,
Yes.
D is going to be the
Any
right answer.
hormones when giving in pulsatile and intermittent, it act as a stimulant.
Okay.
And
This
continuous
because
infusion.
this is the main effect of intermittent parathyroid hormone.
Yeah.
Okay, remember that the parathyroid hormone always bound to the osteoblast.
Yeah.
Even when it causes the bone resorption, even then the main receptor of parathyroid hormone is present on the osteoblast. Okay.
Osteoblast.
Okay.
Okay.
And then the rankle is secreted by the osteoblasts that bonds to the rank receptor on the osteoclast. Okay, which
Osteoblast.
is going
Oh.
to stimulate the osteoclast and increase calcium and bone resorption. Parathyroid hormone never binds to the osteoclasts. Okay, remember this important thing. It
Mm.
only binds to the osteoblast,
Osteoblast.
whether it is causing bone resorption or bone stimulation. Okay? The
Okay.
osteoblasts are going to release rankle, which is going to bind the rank receptor on osteoclast, which further on going to stimulate the osteoclast. Okay? Remember this thing. Okay? So stimulation of the osteoblast activity. Okay. Which of the following is the most likely mechanism of action of this patient medication? Okay. What is the diagnosis in the patient? It is a
Bladder outlet
64-year-old
obstruction. BPH.
BPH.
64-year-old.
BPH.
Yes.
PH.
Yes. A
Straining and dripping.
64-year-old man who has a 6-month history of difficulty urinating and frequent straining and dribbling. His symptoms increased over time and affect his quality of life. Okay, the physician prescribed that gives the patient moderate symptomatic relief, but that drug also decreases the libido and impaired the erectile function. But the patient is suffering from prostatic, benign
PH.
prostatic hyperplasia. Okay.
Hyperplasia.
What drugs are used for the treatment of a BPH?
Finasteride.
Tamsulosin.
Androgen antagonist.
Alpha.
Amsulosine.
Alpha.
One is
Tamsulosin.
tamsulosin, and what is the name of the other drug?
5 alpha reductase.
Finasteride.
Finasteride.
The other drug is finasteride.
Right.
In which drug you are going to see rapid improvement of symptoms?
Finasteride.
No, finasteride will take some time
Do the
to
steroid. Do the steroid.
in tamsulosin. You are going to
Alpha-1
see
antagonist.
yes, in tamsulosin you are going to see rapid improvement of symptoms. Okay, but finasteride you are going to see that symptoms are going to improve by time. Okay, because finasteride causes what? It is going to cause the apoptosis of the prostatic cells. It is going to decrease the size of the cell. Then it will take time. Okay, and tamsulosin is only going to cause the relaxation of the muscle within the prostate. Okay, so there are two. One is BPA, one is tamsulosin, and one is a finasteride. Okay, which one has a side effect that it will also affect the erectile function and the libido?
Finasteride.
I think.
Finasteride.
No, I think 5.
Actually, finasteride.
Yes, one is alpha 1 antagonist, which causes the relaxation of the smooth muscle. In this, you are going to see immediate effects, and the other is 5 alpha reductase inhibitor, finasteride. Okay, there is surgery as well, PDE5 inhibitors. Okay, finasteride is the right answer. Okay, and what is the mechanism of action of finasteride? 5
5
alpha
Alpha
reductase
reductase
inhibitor.
inhibitor.
It inhibits the conversion of a
Testosterone.
testosterone to dihydrotestosterone. Okay, and okay, finasteride, tamsulosin activation. Finasteride, 5 alpha reductase conversion, TST. Okay, used in BPH as well as androgenic alopecia, and the side effects are sexual dysfunction. Okay, and gynecomastia. So the right answer is
A.
A. A is going to be the right answer. Okay. A, option number D. Do you know? Can you name the drug?
Aromatase. Aromatase.
Letrozole.
Yes, aromatase inhibitor and estrozole. Okay.
Yes,
Okay.
yes.
Okay. Let's move on to the endocrine paired androgen receptor interaction. So, Mhm. Well diagnosed and so required supraphysiotic doses of prednisone to control her symptoms. Has no other medical conditions. And is required. What drug does this patient is taking?
Prednisolone.
The patient is
Prednisone.
taking prednisone. Okay. Okay, now we have to tell us why this prednisone causes the osteoporosis in this patient. Increased levels of insulin like growth factor 1. That is seen in what? IGF-1 are involved in what?
I think C is
In
answer.
acromegaly is increased level
Growth.
of insulin, like
Inhibition.
growth hormone when we increase.
Okay, and option number D, what do you think about option number D?
Is wrong because the word inhibit
It's steroid.
osteoclast
Yeah,
Sorry.
Right.
Yeah.
that
steroid
cause bone
increases the
loss.
expression of.
Yeah.
Okay, suppression of parathyroid hormone release. Does a
No, it's
glucocorticoid suppresses the secretion of parathyroid hormone?
no, it's a promote
No.
bone reabsorption.
Okay, now we are left with two options: inhibition of osteoblast precursor cell replication,
Yes, right,
and
is right.
option number A, increased
Because
activity of osteo.
osteoprotein
No,
protects the
number A is
bone
wrong
and
because it's inhibition
building.
bone resorption. It's protective, not cause bone loss.
Like
Yes,
body first activate the osteoblast, which further activate the osteoclast. So osteoprogetin blocks the head of the
yes. If
receptor.
the osteoprotein is increased, you are going to see bone formation.
Yeah.
If the
This is
osteoprotein is
basically done by
increased.
estrogen.
Yes, and in the question he is asking bone resorption, not bone formation.
Yes.
Increased activity of osteoprotein is going to cause bone formation,
Protection.
not bone loss. Okay. The
Okay.
only option that is making sense here is option number C.
See.
Option number B, if there is increased level of insulin like growth factor, there you are going to see increased bone formation.
Yeah.
Okay. Okay. Suppression, it does not causes the suppression. Okay. Let's see. Option number C is the right answer. Okay. Yeah, ankle receptor application in the green as receptor activator of a nuclear factor K beta ligand. Okay, receptor activator of nuclear factor K beta ligand. Okay, so we see the formation. Okay, this is the whole process that the glucocorticoids inhibits the conversion of precursor cells into the osteoblasts. Okay, and it will decreases IGF-1. It will decreases the osteoprotein as well. It will increase the rank and rankles, and it will decrease the sodium renal calcium reabsorption as well. All of these factors are going to lead towards osteoporosis. Okay.
Doctor, does it do to the NFK beta?
What is the mechanism of action of glucocorticoids?
It it inhibits the insulin
Inhibit.
secretion.
It
Inhibits the
inhibits
inflammation.
exactly.
Here is the phospholipids from the bigger.
Look at it. It inhibits the NFK beta. Okay, and it is going to cause osteoporosis as well. Okay, so line number C, inhibition of the receptor of the a receptor activator of nuclear nuclear factor kappa beta is also right, but it is not the main cause. That is how it is going to lead towards the osteoporosis. Okay. He's asking specifically the effect of how does glucocorticoids causes the osteoporosis. Okay, so that's why even we glucocorticoids that's why even the option number D is right. It is not the cause of the osteoporosis here. Okay, let's move on to the next one. Which of the following is the best explanation for the therapeutic effects of this agent? What agent we are using? Anastrozole.
A.
Yes, we have just discussed
Decrease
the
androgen
mechanism of action
aromatization.
of anastrozole. What is the mechanism of action of anastrozole?
Decrease aromatization.
It will inhibit what enzyme?
Aromatase.
Aromatase. And what does aromatase does?
Peripheral conversion of
Androgens to estrogen.
androgens to estrogen.
Anastrozole
Androgens
aromatase
to
inhibits
estrogen.
conversion of androgens to
Estrogen.
estrogen. So what would be the right answer here?
Option A.
A.
Okay. You are going to see such type of simple questions in your exam as well. Okay, so that's why especially in pharmacology, if you start reading the question from the bottom, it will help you a lot in the real exam. It will save a lot time. Okay, especially in the pharmacology. In the patho and pathophysiology questions, you have to read the whole question. Okay, but in the pharmacology question, most of the time, if you only read the last two lines, you will not need to read the whole question. Which of the following should be periodically monitored during this patient treatment? Transdermal testosterone therapy is initiated.
Syria, you want to create.
And we know in androgen abuse, we did a question
Because,
on androgen abuse yesterday.
yes, because it is increase the RBC synthesis and lead risk of thrombosis.
Anabolic androgen abuse, it will increase the erythrocytosis. We are going to see increased risk of thromboembolism. Okay, in those patients which are going to use androgens. Okay, that it is also going to cause small testes, gynecomastia, and decreased testicular sperm size, azoospermia. Okay, other than that, the main thing that the patient usually dies from is the increased hematocrit leads to increased risk of thromboembolism. And many bodybuilders and those patients who are using androgens die due to this. Okay. So which of the following should be periodically mentioned, is periodically monitored during this patient treatment?
Hematocrit.
Hematocrit.
Hematocrit. Okay. Which of the following changes in testosterone and dihydrotestosterone levels are most likely to occur this patient after the initiation of therapy?
B.
Uprolite
Yeah.
therapy is initiated. What is the mechanism of uprolite
GnRH
therapy?
analogs.
GnRH
GnRH
and
as an analog.
GnRH analog, yeah.
Yeah, very good. And
Really, it increases the LH level and then it falls down.
okay. Aromatase inhibitor leuprolide. Okay, it is a GnRH receptor analog. When used in continuous fashion, first transiently act as a GnRH agonist, subsequently act as a GnRH antagonist. Down regulates the receptor, and then the FSH and LH are going to decrease, and eventually estrogen and testosterone is going to decrease as well. So, when you are using it in a continuous manner, not in the pulsatile manner. Okay, if you are using it in a pulsatile manner, you are going to it is going to act
Always
as
on
an
the
agonist.
agonist.
Okay, if you are using it in a continuous manner, you are first going to see a spike. Okay, because at early stage it is going to act as an agonist. Okay, and then you are going to see a drop. Okay, because then after it is going to act as an antagonist if you are using it in a continuous fashion. Okay.
Same as PTS that we used in the previous
Okay, so
question.
what
Few
would be the
questions
right
back.
answer?
Option B.
B.
Option B. Why
Initially
option number?
increased, then
Okay, why option number D is not the right answer? You are seeing a spike in option number D as well.
yeah, but
Yeah,
the other hormones
The
not
solid line
increasing.
represents
yeah,
testosterone
it
and the
went
DHT
up.
comes
That
Yeah,
is
Sudden rise and fall.
yeah,
sudden rise and fall. And
yeah.
it will also be replicate in the DHT levels as well. Okay, because DHT is directly dependent on the testosterone.
it's a fellow,
Okay,
that's a fellow.
adenocarcinoma. Okay, talk to me. Initially stimulates and then it is going to decrease. Which of the following type of medication is most likely be responsible for this patient? Symptoms. See the options. Okay.
Like questions, Cindy?
Yes, with a complex medical history comes to the clinic due to change in her body habitat. She says her legs are like sticks while her belly is big. Legs are like sticks while his belly is getting bigger. Okay. Increased fatigue but does not excessive daytime stimulants. Okay. She is distractible. Okay. There is loss of adipose tissue from the extremities and face with a noticeable increase in abdominal width. Okay. HMG option number B. Option number B is statins, right?
Statins, yes.
What are the side effects of statins?
Muscle pains and
Hepatotox.
hepatocyte toxicity, increase the
Yes.
LFTs.
Myalgias and hepatitis, yes, and in they can causes and they increases the LFTs as well. Okay, they has nothing to do with fat redistribution, right? Does loop diuretic has anything to do with fat distribution?
No, no. It's just cause hypokalemia,
Okay,
hypocalcemia,
NSAID,
hypomagnesemia, weight
do you
reduce.
know does any NSAID causes these symptoms like
No,
No.
lipodystrophy symptoms, PPIs,
no,
No.
no, it's omeprazole. Okay. No, they have the other effect, not this one.
thiamazole or PTU?
A granulocyte interference.
Okay, SSRIs.
A
SSR also not. This is serotonin syndrome, but not the dystrophy of the fat dystrophy. This
So we are left with only
HIV treatment, antiviral, antiretroviral.
So do you know the name of the drug which causes this? Name of the drug which causes this? Means HIV drugs, antiretroviral. This is a drug which causes lipoatrophy.
No, rotanavir, darunavir, no, this one.
Weight gain.
It's like protease inhibitors.
Yeah, but
Yeah,
it was written in the previous first aid. But I don't know where it is written in this new first aid. It is written in the previous first aid. Lipodystrophy is caused by protease inhibitors.
Sarbodine and stavudine.
But it is not written in the new first aid. I don't know why. I think so. It is written in the general pharma side effects as well. General pharma side effects. Lipodystrophy. Other than antiretroviral drug, which other drug can also cause this?
Insulin.
Insulin can also cause this. Okay, drug reactions, cardiovascular. Diarrhea, pancreatitis, pseudomyelitis. It was used to written in the HIV drugs, but I don't know where it is. Here it is. Fat redistribution caused by protease inhibitors, glucocorticoids. Okay, protease inhibitors, the one which we use in HIV, antiretroviral therapy. Okay, they can also cause the fat redistribution, which we are seeing in this patient. Okay, that her legs are getting stays, legs are like sticks while her belly is getting bigger. The Cushing syndrome body. Okay, loss of adipose tissue from the extremities and face with a noticeable increase in abdominal growth. Okay, the two drugs which are involved are protease inhibitors and glucocorticoids. Okay. Lipodystrophy. Okay. Which of the following is most likely cause of reduced bone density here? Okay. Medical history is notable for locally advanced prostate cancer, for which chronic leuprolide therapy has been prescribed. And we know when leuprolide is used in a continuous fashion, what will happen?
It will decrease androgen.
It decreases androgen.
It will act as an
Estrogen.
antagonist.
Yes.
The G and RH levels are going to increase or decrease?
Decrease.
Decrease.
And the FSH LH levels?
Decreased.
And the estrogen and testosterone levels?
Decrease.
Yes. Okay. So why this patient will have a osteoporosis?
Due to decrease
Because
of
of what?
estrogen.
Decrease estrogen. Decrease
Estrogen
estrogen.
and testosterone.
Testosterone, yeah.
Yes, because when used in chronic fashion, it acts as an antagonist, and due to which we are going to see decreased estrogen and the testosterone. And we know when the estrogen and testosterone estrogen is less, the patient will face osteoporosis. Leuprolide. Okay, continue happen when used in continuous fashion. First act as agonist, then act as antagonist, and it is going to cause decrease estrogen and decrease testosterone in males. Okay. Okay, now I will make a blog for the rest of the endocrinology questions. Okay. So, okay. So the endo is if the pathophysiology and the pharmacology is finished. Now anatomy, physiology, embryology, genetics, histology, and the all the other ones are left. Okay. Just give me a minute. I will make a block.
How many questions are left in endo?
I think so. There are a total 200 questions, and we have done almost 2 blocks of patho and pathophysiology 80 and 51 questions of these. So 131 questions are done, 70 questions are left.
Are we
70
finishing
questions are.
today?
No, it is, I think so. We will finish tomorrow. Maybe it will take 1 or 2 more days. 1.5 days. We need 1.5 days to finish endo. Okay, then our total questions will be done is 260 plus 200, 460 divided by 3600. Then 13% U world is going to be finished. Okay. Hopefully, we will finish 33% U world in this month. Okay. Our goal is to do 1200 questions within a month and to cover the whole U world within 3 months. Okay.
Inshallah.
Okay. So in this way, you are going to also revise whole of the U world. Okay. If we do 1 block a day, 40 questions a day, then you will be able to finish the whole U world within 3 months. Okay. I will let you know the topics before they starting the block, so you people also come prepared. Okay. Now let's make a block.
Please don't forget to send us the QID as early as possible, please. The question.
Okay. I will share the QIDs as well. Okay. Let's see. Just anatomy, embryology. Okay, so there are 40 questions of anatomy, physiology, and embryology. Okay, we will first do those 40 questions. Then there are almost 30 questions of immunology, genetics, and biochemistry, okay, which are related to the endocrinology sections. Okay, we will also cover those microbiology, histology, genetics questions as well. Okay, after covering the anatomy, physio, embryology. Okay, let's start the anatomy, physio, and embryology. Okay. Mm. 41-year-old man comes to the office due to 4-month history. Which are the following the most likely cause of the patient disorder here? These are the options. Comes back to the question. Okay, the patient is 41-year-old, fatigue, headache, weight loss, sweating, palpitation. Hyperthyroidism symptoms or hypo?
Hyper.
Hyper.
Hyperthyroidism.
Okay.
Hyper.
Hyper, weight
Weight
loss, sweating,
loss.
palpitations. Okay. Lead lag and fine hand tremor. Okay, hyperthyroidism. Mild diffuse enlargement of the thyroid gland. Okay. There is goiter as well. Free thyroxine is elevated. Total T3 is also elevated, and the TSH is also elevated. TSH is also elevated. Okay, so TSH is elevated. Now you people tell me what is the main pathological site? Is it the thyroid gland or is it the pituitary?
Pituitary.
TSH is
Pituitary.
it is pituitary. Okay,
Yes.
because if the main pathological site is thyroid, like some type of tumor or something like that is present in the thyroid, which is producing large amounts of the thyroxine hormone. What will happen to the TSH level? If the
Decrease
primary site of
by the negative
TSH is going to be decreased if the cause is thyroid, if the main pathological site is thyroid. Okay, in that case TSH is decreased, but in our question we can clearly see that TSH is elevated. That means that it is secondary hyperthyroidism, right? Okay, so Graves disease, it cannot be, it is primary. Painless thyroiditis, primary. Thyroid cancer, no. Elevated TBG, elevated TBG cannot explain increased TSH. The right answer is,
D.
D.
the right answer is pituitary tumor. Okay, the patient has hyperthyroidism, secondary hyperthyroidism. Okay. Serum thyroid function testing, which would most likely reveal which of the following. Okay. A 46-year-old woman comes to the office for a follow-up. Okay. 6 months ago, the patient underwent total thyroidectomy. Okay. Total thyroidectomy, followed by a radioactive iodine ablation for invasive follicular thyroid cancer. She was prescribed levothyroxine, okay, to prevent thyroid cancer. After the surgery, she was prescribed levothyroxine. The patient has had a 4.5 kg unintentional weight loss despite having a normal appetite. Okay, she has weight loss. Okay, blood pressure is elevated, pulse is elevated, fine hand tremors, sweaty palms. Hyperthyroidism symptoms or hypo?
Hyper.
Hyper.
Hyper. Hyper.
Hyperthyroidism symptom. What is the cause of these hyperthyroid symptoms?
Too much levothyroxine.
Levothyroxine.
Yeah, patient is taking too much levothyroxine. If the patient is taking too much levothyroxine, what will happen to the TSH levels?
Decrease.
Decrease.
Think
Decrease.
it
Should
decreases.
decrease.
Decrease. And what will happen to the thyroxine levels? The patient is
Increased.
increased. The patient is a hyperthyroidism, right? So the right answer is going to be increased T4, T3. Is a hyperthyroidism case. Exogenous thyrotoxicosis, right? Which of the following most likely to be denervated as a result of this incident?
Hello.
Okay, so we are doing a surgery in this patient, total thyroidectomy, and during the surgery, a nearby nerve is injured while ligating the artery and entering the superior lobe of the thyroid lobe, superior pole of the thyroid lobe. Okay, which nerve it is that is going to get damaged at this location?
Superior laryngeal?
Superior,
Laryngeal.
superior laryngeal nerve or recurrent laryngeal nerve?
No, no, recurrent coming from down.
Superior.
Is the part of the larynx is superior.
Yes, the superior comes from the upward and the recurrent comes from the downward location.
Downward. External branch of.
Yes. Okay, let me. Remember, it is written in the thyroid cancers.
This is the superior branch that it give the two branches.
Okay.
One is internal, one is
Yes.
external.
External is involved.
Internal is the sensory, which give the sensory innervation above the vocal cord, and the external is the motor that's going to the cricoid
Okay, see.
muscles.
Transaction of the recurrent laryngeal nerve during ligation of the inferior thyroid artery. In our question, we are talking about the superior thyroid artery, right? Okay. If the recurrent is affected, then you are going to see dysphagia, dysphonia. Okay. Injury to the external branch of the superior laryngeal nerve during ligation of the superior thyroid pedicle. Okay, and it will lead to what? It will lead to the
Hoarseness.
loss of the tenor muscle. Okay, usually noticeable in professional voice user. Do you know which muscle is responsible for the tension?
Cricothyroid.
Cricothyroid muscle is the one which is responsible for the development of the tension in the vocal cords. Okay, and all the other muscles are supplied by recurrent laryngeal nerve. Okay, cricothyroid. Okay. If the superior is damaged, then the superior branch of the superior laryngeal nerve, and if the inferior pedicle is damaged, then the recurrent laryngeal nerve, and all the other muscle other than the cricothyroid are going to get damaged. Okay. Which of the following is the most likely cause of this patient's gynecomastia?
D.
Okay, a 35-year-old man comes to the office for evaluation of enlarged left testis. Okay, decreased libido, erectile potency for the last 2 months. Okay, no chronic medical condition, takes no medication, notable for significant enlargement of the left testis. Okay, and bilateral gynecomastia. There is enlargement of the left testis and the bilateral gynecomastia. Okay, other than that, the serum beta HCG is markedly elevated. Okay, and scrotal ultrasound reveals a 3.1 centimeter irregular testicular mass with cystic areas. Okay, what is the diagnosis here?
Testicle tumor, which
Yeah,
increase too much
that is testicular
testosterone.
tumor that is producing increased beta HCG. Okay, okay, that is the cause here. Okay. Ovarian tumor. And in which cell we are going to see elevated beta HCG? We are going to see beta HCG elevated in seminoma, yolk sac tumor, carcinoma, and the embryonal carcinoma as well. Okay, in Leydig cell tumor, especially, we are also going to see gynecomastia as well. Okay, causes of gynecomastia. Why does gynecomastia occurs? Due to increased
Increase of
estrogen,
testosterone. Yeah.
increased estrogen as compared to androgen. Okay, whenever you have increased estrogen as compared to the increased androgen, then you are going to see bilateral gynecomastia. Okay, okay. In this patient, which of the option is telling us that the estrogen is high, estrogen is elevated?
D.
First
Increased.
one.
What is the
Leydig
function of
aromatase.
aromatase? What is the function of aromatase?
D.
Combination of
D is converting the
Conversion.
testosterone to the estrogen. And there is too much estrogen, and the aromatase converted this testosterone to the estrogen.
Okay, aromatase is the one which converts testosterone into a estrogen. Okay, and one other thing that is going to happen in this patient, that then when you have large amount of beta HCG, it is going to suppress the secretion of GnRH. Okay, that is one more thing that is going to happen in this, and that is going to suppress the testosterone production in this patient. Okay, and as compared to the androgen, estrogen is are going to get elevated. Okay, decreased adrenal androgen production are seen in a congenital adrenal hyperplasia 17 alpha hydroxy, a 17 alpha hydroxylase enzyme deficiency. In that, you are going to see adrenal androgen deficiency. Decreased hypothalamic secretion of the GnRH leads to decreased testosterone production. Okay, that can also lead to decreased. However, gynecomastia is present. The main case is the germ cell tumor. Okay, yeah, this is not the right answer here. Physiological medications, testicular tumor, HCG secretion, impaired and increase aromatization in the Leydig cell. It will lead to increased estrogen production. Which of the following is most likely responsible for the bone abnormality in this patient? What are the abnormal findings in this patient?
Hyperthyroidism.
The patient had a mid-thoracic back pain. It is a 70-year-old man that started after a ground fall. The patient has weight loss and weakness for the past 2 months. Okay, sweaty palms and fine hand tremor. Blood pressure is also elevated. Pulse is also elevated. Okay, all the hemoglobin, calcium, creatinine, vitamin D levels are all normal. TSH is undetectable. That means it is hyperthyroidism
Hyper.
and primary hyperthyroidism. Okay, the X-ray reveals a compression fracture of T7 vertebra and the diffuse demineralization of the bones. Okay, how does hyperthyroidism leads to the decrease, it leads to demineralization of the bone.
So the T3 is going to affect on osteoclast, and the osteoclast is going to do resorption of the bone and increase the calcium. And this resorption of the bone is going to do osteoporosis.
Okay. Is cardiovascular. Stimulates what? Osteoclast cells. Okay, it stimulates the osteoclast, and this will going to lead to increased bone resorption. Okay, it will increase bone resorption by the stimulation of osteoclast. It will not have any effect on calcitonins or the parathyroid. It will not regulate those, but it will increase the differentiation of osteoclast. And by activating the osteoclast, they are going to increase the resorption of the bone. Okay. Okay. Hyperthyroidism increase stimulate osteoclast differentiation, and that is going to increase the bone resorption. Hyperthyroidism. Administering this therapy will most likely result in which of the following hormone level changes in this patient. Okay. Okay. So a 43-year-old woman comes to the office due to increased fatigue, weight gain, despite the decreased food intake. She states that I have not been feeling like myself too lately. Okay, the patient asks to be referred to a dermatologist as she has always and now has become dry. Okay.
Her hair has been thinning. Okay, she hopes that a dermatologist can help with that. Laboratory evaluation shows high TSH and low T3 and T4.
Can't hear you properly, sir.
Who is fatigue, whose energy level after T3 supplementation increases. And now
Doctor, your voice is not too clear.
Okay, so she started T3 supplementation here, right? So now he's asking in the question what will happen to the TSH, T3, T4 if he is going to start this medication. Okay, if he started the T3, what will happen to the TSH levels?
Decrease.
Option A and B are eliminated. T3 are going to be increased. Okay. What will happen to the T4 levels? What will happen
As
to
T3 not converted to T4, I think
It was decreased.
it will decrease
It will
or
decrease.
yes.
Okay, first tell me, is T4 is made from T3 or the T3 is made from T4?
T3 made from
T3
T4.
made from T4.
It's made from T4.
Yes, T3 develops from T4, right? If the patient was taking T4, then T3 is also going to get elevated. Okay, because it is an end product. But if because the patient is already taking T3, It is not like the T3, there is no enzyme which can convert T3 into T4. Okay, so T4 is not going to get increased. Okay, because it is not going to be produced here. Okay, T4 is going to decrease. Okay, okay, because he is already taking up finished product. Okay, okay, what will happen to reverse T3?
Decrease.
Reverse T3 is also going to be decreased. Okay, T3 cannot be converted to reverse T3. Okay, reverse T3 develops from what?
T4.
From
T4.
T4.
RT3, reverse T3 develops from T4. Okay, and T4 is less, so T3 is also RT3 is also going to be less. Okay, RT3 is a metabolically inactive byproduct of peripheral conversion of T4. Of T4. 5-deiodinase converts T4, the major thyroid product, to T3 in the peripheral tissue. Okay, you can convert T4 to T3, but you cannot convert T3 to T4. Remember this. Okay, there is T4 and T3. T4 is converted into T3 and RT3, and it can convert to T3 in the peripheral tissues. Okay, so the right answer is
D.
D. Which of the following processes is most likely to be impaired in the preterm infant lacking these tissues? Okay, researchers are studying factors contributing to high morbidity and mortality in infants born prematurely. They find that compared to term infants, preterm infants have a lesser amount of specialized connective tissue found in the supraclavicular area and around major blood vessels and abdominal organs. These highly vascular tissue composed of cells containing major lipid droplets and abundant mitochondria. Okay. What tissue he is talking about?
Brown fat.
Brown fat. He is talking about brown fat in the infants. Large amount of. Okay. So, uncoupling proteins are found in brown fat, which has more mitochondria than the white fat. And why this brown fat has more mitochondria? So it can, so it can produce what? Heat. It can produce heat. Okay. So because we know that in infant, the infants requires thermogenesis to maintain their body temperature. That's why they require much more energy reserve. And to compensate for that energy, the the baby has brown fat instead of the white fat. And brown fat has much more mitochondria. Okay. Okay. So what will be the answer here?
E.
So thermogenesis is going to be impaired if anything is going to happen to the brown fat. Okay. Brown fat, supraclavicular, preterm infant, impaired thermogenesis, abundant mitochondria.
Because the neonates only produce, infants produce the heat by this mechanism, brown fat. They don't shiver that, there is no shivering.
Yes. Okay.
And very, very prone for hypothermia also.
Okay. Now comes to this question. Okay, a newborn baby is found to have a serum TSH above and serum thyroxine below. Okay, that means the patient has hypothyroidism, right? Was born at 39 weeks gestation via spontaneous vaginal delivery. Okay, his mother has no medical conditions. Okay, length and ultrasound shows normal size thyroid gland in the a a okay normal size and in the appropriate location as well. Okay, is it central hypothyroidism?
No.
Why? Why it is not central? Because
Because
in
in case of
central,
central,
In
TSH
center,
would be
all
less.
decrease.
TSH is
yes,
TSH
in
also,
central
all decrease.
TSH is going also going to be decreased, right? Okay. TSH receptor stimulating antibodies. These are found in which disease?
Grave disease.
Graves disease.
Grave disease. And we know in Graves disease, we are going to see hyperthyroidism. Okay. Option number B, generalized resistance to thyroid hormones. If there is resistance to thyroid hormones, what will happen to the thyroxine levels?
Increase.
Increase.
They are going to
Increase T4 and TSH.
yeah,
Increase.
but in our case, the serum thyroxine is below the normal
Below.
range. Okay, we are left with C and D. Thyroid hormone binding globulin deficiency. If there is a deficiency of thyroid hormone binding globulin, what will happen to the TSH and the
Increase. TSH will decrease. Our
Increase. Increase.
hormones will increase. T3.
are you sure?
No. The total before it is going to increase.
Only the total is going to be effective. TSH levels are going to be
Okay, no,
normal.
no.
Free T4 is also going to be normal. Okay, everything is going to be normal. Only the total is going to change, and the bound thyroxine is going to change. Okay,
Yes, got it. Yeah.
so the right answer is thyroid gland resistance to TSH. Okay. Okay, which of the additional finding is most likely to be present in this patient at this time? Okay, first we will try to make a diagnosis here. Had an upper respiratory infection a month ago. Neck pain, upper respiratory infection, nasal congestion. Okay, so viral flu-like symptoms. Okay, okay, pain in the anterior neck. Okay, mild fever, palpitation, excessive sweating. Symptoms of hyper or hypo?
Hyper.
Hyperthyroidism.
Hyperthyroidism. Okay, sweaty palms, fine hand tremor, brisk deep tendon reflexes, suppressed ESH, elevated free thyroxine levels, ESR is elevated. Diagnosis.
Viral
Decovering
thyroiditis,
thyroiditis.
decoversion.
It is decovariant thyroiditis. The TSH, the
Initial
patient
stage.
has a viral flu-like symptoms before the development of the disease, and there is
Thyroid is
ESR is
standard.
elevated, and the thyroid is tender. Which all of these are the symptoms of a decovariant thyroiditis. ESR, thyroid tender, preceded by a viral infection. Okay. Now we will see which of the following is most likely to present in this patient. Thyroglobulin levels are going to be low, high. What will happen to the thyroglobulin levels? Are they going to be low, normal, or high?
Unchanged.
No, 10.
Normal.
Normal.
They are going to be elevated. They are going to be elevated. Why? Thyroglobulin is stored within the within the follicular cells. Okay, when the cells are damaged and the thyroxine is released, so along with thyroxine, the thyroglobulin, which is usually present inside the cells, is also going to be released within the bloodstream. Okay, because the main cause of the increased thyroxine is here is the damage to the thyroid cells, which is leading to the release of the preformed thyroxine hormone. Okay, and other than thyroxine, which other thing is also present in the thyroid cells? Thyroglobulin. Okay, thyroglobulin is also present inside the cells. Okay, our patient is showing symptoms of hyperthyroidism.
Hyper.
Hyper. Option number D is eliminated. Elevated thyroid peroxidase antibody level, or B? Option number A, which one is going to be the right answer?
Answer is B.
A.
B.
Option
B.
number B is going to be the right answer. Why?
Any iriditis, any inflammatory disease of the thyroid decrease the iodine uptake.
Yes, because
Because
now the cells are damaged. It is itis. Itis. Itis means inflammation. Hashimoto thyroiditis. Decovariant thyroiditis. There is inflammation of the cells, and that cells are now damaged. They are no longer be able to produce the thyroxine hormone until or unless these cells recovered after some time. Okay. And so during the inflammation, these cells are no longer be able to use the iodine to produce new thyroxine. Okay, the hyperthyroid symptoms are due to the release of the thyroxine from the damaged cells due to the inflammatory process. Okay, that's why the iodine uptake is going to be low here. Okay, and thyroid peroxidase antibodies are elevated in which condition?
Autoimmune.
In the Hashimoto thyroiditis. Okay, not the subacute, in the Hashimoto. Okay. Okay, patient has symptoms of hyper or hypo?
Hyper. Grave
Hyper.
disease.
Okay, hyperthyroidism. Okay, so if I say the diagnosis is Hashimoto thyroiditis early stage, if I say the diagnosis is Hashimoto thyroiditis early stage, because in the earlier stage you are going to see hyperthyroidism symptoms. Why would my diagnosis be incorrect?
Hypothalamus, I guess.
Thyroid eye disease and
Yes, because thyroid eye disease, the patient has exophthalmos. That is very specific for the
Grave disease.
Graves' disease. You are not going to see that in Hashimoto thyroiditis. Because what is the pathophysiology in the exophthalmos? That the TSH receptor, and you require
And
TSH receptor
lymphocytes.
antibody. Okay, because the eye cells have TSH receptors located within them. Okay, if you have a TSH, specifically TSH receptor antibody, that antibody can stimulate those fibroblasts, and then they are going to increase in size. They are going to accumulate the gags, and there's water retention in them, and due to which we are going to see exophthalmos. Okay. Okay, activation of T cells, lymphocytic infiltration of retroorbital cells, increase cytokines, fibroblasts, increase osmotic pressure, and exophthalmos. TSH receptors on thyroid, dermal fibroblasts, and orbital fibroblasts. Okay, you require a TSH receptor antibody. And what type of antibody is present in Hashimoto?
Thyroid peroxidase.
Thyroid peroxide.
Thyroid
Peroxidase.
peroxidase. Okay. So what will be the right answer here?
C.
Thyrotropin receptor antibody. Thyrotropin means TSH. Okay. Okay. So the patient is type 1 diabetes mellitus. He has recurrent hypoglycemic episodes. He previously had difficulty controlling his high blood glucose level, but over the past several weeks, his blood glucose has intermittently dropped to less than 50 with symptoms of hypoglycemia. Okay. He no recent changes in diet, activity levels, insulin dosage, or other medical therapy. Okay. Medical condition includes CKD from diabetic nephropathy. GFR has declined to 20. Very less. And under consideration for initiation of hemodialysis. Physical findings are unchanged from the previous office visit three months ago. So why the patient is experiencing recurrent episodes of hypoglycemia here?
Decrease renal insulin
In-
clearance.
Yeah. Decreased level of insulin.
Because having chronic kidney disease.
The insulin which we used in the treatment of the type 1 diabetes is a is excreted through
Kidneys.
the kidneys, and if the kidney functions is not there, if the kidneys are deranged, what will the body will face difficulty in excretion of the insulin, and due to the increased half life of insulin, then we are going to experience the symptoms of
Hypoglycemia.
hypoglycemia. Other than insulin, what other drugs in what other drugs we also need to see the GFR, the creatinine levels? What other two anti-diabetic medications?
Metformin.
One is metformin and the other is
SGLT.
Sodium glucose co-transporter.
Yes.
and
Closing.
SGLT2 inhibitors as well. In that too, because the efficacy is dependent on the GFR. Okay. So the cause of here of hypoglycemia is that the renal insulin clearance is decreased. Okay, because the patient GFR is way low. Okay, that's why there is increased risk of hypoglycemia in this patient. Okay,
It was metformin and insulin, and the third one was.
SGLT2 inhibitors.
Thank you.
The infant most likely has a deficiency in which of the following enzyme? The patient karyotype is 46XY. That
Male.
means the patient is a male,
Male.
right?
Male.
Okay. The infant's external genitalia are atypical and ambiguous. There is an intermediate clitorophallic length and a perineal urethral opening. Mobile masses are present palpated bilaterally in the eh, inguinal area. Serum testosterone is within the normal limits. Okay. What will happen to the testosterone levels in 17 hydroxylase deficiency and 21 hydroxylase deficiency?
In 17 decrease, 21
Oh,
is
decrease.
increase.
Yes, in 17 they are going to,
Decrease.
and in 21
Increase.
Increase.
but in our question it is clearly mentioned that the testosterone are within normal.
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 Okay, yeah. Okay, renin, androstenedione. Okay, test sex hormones decrease, increase in 17 and 21. Okay, sex hormones, testosterone. Okay, okay. So it is not B and C. What is the function of aromatase?
Conversion of
Testosterone to
testosterone to estrogen.
estrogen.
Testosterone to estrogen.
Do you think the symptoms which we are seeing in this patient, the patient is a male baby? Okay, it is a male. Is the patient, the signs and symptoms are due to low estrogen?
No.
No, they
No.
are not due to low estrogen. Okay, we
Ineffective
are
testosterone.
okay. They are due to low. They are the male external genitalia is affected. Okay, the male external genitalia development is dependent upon which hormone? Ex-
DHT.
Active form of
Dihydrotestosterone.
testosterone.
Sex determining region of male. SRY.
Who's Netflix?
The external male genitalia is dependent upon the dihydroxytestosterone, and the internal male genitalia depends upon the testosterone. Okay, our the patient has mobile masses within they are well circumscribed mobile masses palpated bilaterally in the inguinal area. That means that there are testes present within the patient. Okay, there is internal genitalia, there is proper internal genitalia development. The only issue we have is in the development of the external genitalia, and we know which is in the development of the external genitalia, dihydroxytestosterone is involved, and that is developed from the testosterone by the action of what enzyme? 5 alpha reductase. Okay. 5-alpha reductase, autosomal recessive, inability to convert testosterone to dihydroxytestosterone, atypical genitalia until puberty when increased testosterone causes masculinization and increased growth of external genitalia. Okay, are normal. Testosterone levels are normal. Remember this thing. LH is also going to be normal. Internal genitalia is also going to be normal. Okay, let's move on to the next one. Which of the following is the most likely etiology of this patient thyroid function test?
Well, we're not just fuck up. Bala when man.
Okay, there's a 7-year-old boy brought to the clinic for a well-child visit. Over the past, the patient has become fidgety, impulsive, inattentive, restless, leading to progressive decline in his grades. Weight is in the 5th percentile, height is in the 50th percentile, takes no medication or supplements. There is diffuse enlargement of the thyroid gland. Okay, TSH is elevated, thyroxine is elevated, chronic autoimmune thyroiditis.
Get away from there. Now.
Do you think the cause is Hashimoto thyroiditis here?
No.
No. Because in Hashimoto thyroiditis, we are going to see a
High
increase.
THS but the low T3, T4.
Yes. But in this, we can clearly see that TSH is also elevated and T3 is also T3, T4 is also elevated. Okay.
Something syndrome.
No.
Do you think the answer is Graves' disease?
No. There's
What
no
will
sign
happen to
symptoms
the
of Graves' disease.
TSH levels in the Graves' disease?
Low.
TSH level will be
Below.
decrease. Decrease and T3, T4 will be high.
Elevated thyroxine binding globulin.
Low.
What will happen to the TSH in elevated thyroxine binding globulin?
It's not going to affect it.
Will be normal.
They will be normal.
Normal.
Normal, very good.
Only
Organification defect in the thyroid hormone synthesis. What will happen to the T4, T3 levels if we have a defect in the synthesis process?
Decrease.
No.
Decrease. So the only answer that is making sense that the thyroxine and
The resistance
T4 is
to the
also elevated and TSH is
hormone
also
receptors.
elevated is option number E, right?
Yeah.
All the other options cannot justify the laboratory findings we are seeing in this patient, right?
Yeah.
Early treatment with levothyroxine is indicated primarily to prevent which of the following. So there's a newborn which have hypothyroidism, okay, and early treatment with levothyroxine is indicated primarily to prevent. What is the name of this condition?
Congenital hypothyroidism.
Cretinism.
Cretinism. Hypothyroidism in the children is called
Cretinism.
it is called cretinism. Okay. Which of in cretinism, which of the abnormality can be permanent if the treatment is not started immediately?
Mentally retarded. When the brain will be not
Mental
developed.
retardation.
Yes.
Congenital hypothyroidism, more formally called cretinism. Poor brain development. Okay. So the main thing is the neurocognitive decline. Okay. If you start the treatment early, we can prevent the neurocognitive decline. Okay. Remember this.
Fún mi ní bọ́ọ̀lù yẹn. Ẹ lọ mú bọ́ọ̀lù yẹn wá.
A 21-year-old man comes to the clinic for a routine health maintenance visit. During testicular examination, is found to have a single testis in the scrotum. Laboratory evaluation shows an elevated serum FSH and a normal serum LH. Okay. Which of the following is most likely decreased in this patient? Decreased. Okay. The LH levels regulate the production of which hormone?
Testosterone.
Testosterone.
LH regulate the production of testosterone hormone. Very good. Okay. And in the question, it is clearly mentioned that the LH is normal. Right? That means the testosterone is normal. Right? Because if there is any fluctuation in the testosterone, we are going to see changes in the LH levels. Right?
Yeah.
So testosterone is normal. If testosterone is normal, dihydrotestosterone is also going to be normal. Okay, we are seeing only change in the FSH level. Okay. Okay, FSH regulates the
Inhibin by negative feedback.
yes, it regulates the inhibin B. Okay. FSH acts on what cells? Leydig cells, and increases the production of testosterone. Testosterone then comes on by negative feedback, decreases the LH. FSH acts on the Sertoli cells and causes the cell to release inhibin B. Okay, and inhibin B then negatively regulates the FSH level. But in this case, that the patient has only one testis. Okay, so now the patient has less Sertoli cells, and if there's less Sertoli cells, less inhibin B is going to be produced. If there's less inhibin B is going to be produced, FSH level are going to get elevated. Okay, FSH is involved in inhibin B production, and LH is involved in testosterone production. Okay, remember this difference. Inhibin B inhibits FSH. Okay. Inhibin B is involved in the regulation of FSH. Inhibin B. Okay, what will happen to the sperm count if you remove one testy? What will happen to the sperm count?
Decrease.
Decrease.
Sperm count will be
Decrease.
decreased. What will happen to the erectile function? Erectile function is dependent upon testosterone.
Testosterone.
If you remove the one testy, what will happen to the testosterone levels?
Normal. Normal.
Normal.
Normal.
Yeah. In the previous question, we have just did that the LH levels are normal. Okay, why they are normal even if we remove the one testes? Because as a feedback mechanism, LH levels are going to increase and they are going to cause the compensatory testosterone production from the one testes. Okay, they are going to increase the production of the testosterone from the Leydig cells, and that compensatory increase testosterone production will going to cause will lead towards the increase leads towards the normal testosterone levels. Okay, at first the testosterone is less, but the Leydig will the LH will increase, and that increased LH is going to increase the ramp up the production of testosterone from one testis, and eventually the testosterone will also become normal. Okay, so and when the testosterone is normal, erectile function will also be normal. Okay.
Isn't erectile function dependent upon the nervous system, or it's the testosterone?
Testosterone.
No, it
Yes,
depends upon the nervous system as well, but it also depends on the testosterone levels as well. Your libido, your erectile function, your skin, the sexual characteristic, they are dependent upon the testosterone levels. Erectile function also has a nervous component as well, that it also depends upon the nervous, but it does not only it not only depends upon the nervous system. There are other factors as well. Okay, like the testosterone levels. Okay.
Okay.
Which of the following set of laboratory finding is most likely to be seen? Excessive weight gain without any change in diet. Weight gain, tired, constipation, no prior medical problems. She has pregnant one, gave infants 3 years ago. There's goiter there, delayed relaxation, hair is thin and skin appears dry. What is it? Is hypothyroidism or hyper?
Hypo.
Hypothyroidism.
Hypo.
Hypo. And what will happen to the TSH levels?
Increase.
TSH levels are going to be increased, right? So remove.
This
T4
primary
levels.
hypothyroidism.
What will happen to the T4 levels?
Decrease.
They are going
Decrease.
to decrease.
T3, T4 will be decreased. THS with negative feedback will be increased.
Okay, so T4 is going to be decreased. Okay. Okay, so the only correct answer that is left is option number A. Okay. Okay, but you can also see that the T3 is normal. Can you explain why T3 is normal?
Because it's T4 is converted like whatever it is.
Okay, so T4 is present in very minute amounts. T3 is present only in very minute amounts in our body. Okay, it is 95% of your thyroxine hormone is in T4 shape, and it is converted into T3 in the peripheral tissues when they are need to use the T3. Okay, and that's why the T3, because it is present in very low amount, is usually remain normal. Okay, because it is a serum T3 levels can fluctuate widely, and and because they are mainly produced in the peripheral tissues and have a very short half life, So that's why the T3 is, usually we say that T3 is normal. Okay, the main determinant is T4, which is the 95% form which is present of the thyroxine hormone. Okay.
Doc, again, your mobile's battery is going to finish all 7%.
Yeah, but we are
Next.
only left 8 minutes. 8 minutes
Okay.
is left.
Okay.
Dr. Hussein, please, could you please explain why T3 is normal?
Because T3 is mainly produced in the peripheral tissues. Okay, 90 to 95% of your thyroid hormone is T4. Okay, when your cells need to use T4, they convert T4 into T3 in the peripheral tissues, which is the active form. Okay, which is only used when they require to use the T4. Okay, because it is produced in very minute amounts only within the peripheral tissues. That's why it is normal. Okay, it does not fluctuate very widely because it was already present in very low amount. Its amount does not fluctuate very widely. Okay.
Thank you.
Thank you so much, Doc. Please, if you don't mind, I have a question. Now,
Yes.
if the option includes reverse T3 as one of the options, what are we going to pick?
Normal.
Normal.
Yes.
Thank you.
But if T4 is low, then reverse T3 should also be low, no?
Reverse T3 has the same concept
Exactly.
as T3. Reverse T3 has the same concept as the T3.
Excuse me, doctor. I also have a question. In what situation
Yes.
T3 gonna be decreasing?
In which condition T3 is going to be decreases?
Yeah.
Okay, like if the enzyme, there is any enzyme deficiency which converts T4 to T3, that there is a mutation which affects the deiodinase enzyme.
I got it. Thank you.
Three drugs affecting over this enzyme: glucocorticoid, beta blocker, and PPU. These drugs
Yes.
inhibit this. Yes.
Yeah. Thank you. Yes.
See, T4 is present in much larger amount than T3, and T3 is used in the peripheral tissues, and it can also produced from T4 by deiodinase. Okay. Other than that, containing on to the major thyroid hormone product is T4. Okay, and it is converted to T3 in the peripheral tissues. Okay. Okay. The preeminence of this patient condition is best explained by traumatic damage to which of the following structures. So let's see what is happening in this patient. Excessive thirst, frequent urination, okay, while being hospitalized, okay. Urine osmolarity after a 4-hour water restriction is 250 ml. Is this low or normal?
Low.
Low.
Okay, if the urine osmolarity increases after 4 hours of water restriction, what will be the diagnosis?
This will be psychological
Polydipsia.
That would
Primary
be
primary
primary
polydipsia.
polydipsia. Okay.
Yes.
Yes, but in this case, it does not improve after water restriction. Okay, let's see. It increases to 700 ml after the administration of antidiuretic hormone. Okay. The patient is starting on appropriate medication over the next 2 years, multiple measures, but is sometimes will always return resisting the restriction. Okay, so what is the main pathology here?
diabetic insipidus.
Yes.
Diabetes nephrogenic or central?
Central looks like central. Nephrogenic
Central, because the
ADH will
urine
not affect.
osmolarity increases after the addition of the ADH. Okay, you can see when you add the ADH, the urine osmolarity is going to significantly increase after adding the ADH. Okay, it is a typical case of diabetes insipidus, and the causes are brain injury, trauma, hypoxia, which is present in this patient, due to which there is less ADH. ADH is produced where?
Posterior
hypothalamus and stored in the
hypothalamus, then
posterior
Posterior,
pituitary.
the
secreted in
hypothalamus.
ADH is produced in hypothalamus or posterior pituitary?
Posterior pituitary with oxytocin.
It is stored in
No,
It is stored in the posterior
stored in
pituitary.
store
the
in the posterior,
hypothalamus.
synthesized in the
From
hypothalamus.
Yes.
Oxytocin and vasopressin, ADH both.
ADH and oxytocin both are produced in the hypothalamus. Stores and release vasopressin and oxytocin both are made in the hypothalamus, supraoptic and paraventricular nucleus. Okay, they are released from there, but they are not made there. So what will be the answer? Hypothalamic nuclei. Okay, not posterior pituitary. They are released from posterior pituitary, but they are not made there. Which of the following is the most likely cause of this patient findings? On routine screening or Okay, so the patient has goiter. Okay, so goiter develops in hypothyroidism, or then the patient has increased TSH and low T4. That means that the patient has hypothyroidism. Hypothyroidism. Okay. Transplacental passage of thyroglobulin. Does that have any effect on the thyroid hormone?
No.
No.
It's out.
Transplacental passage of TSH receptor stimulating antibodies.
It's also no. Out.
So in that we are going to see hyperthyroidism.
It will be increase the function of.
Yes, it will not be decreased. Okay, maternal intake of propranolol.
I think this one.
Okay, if you take propranolol,
It will
what
then
will happen?
convert.
Propranolol only
It
inhibits
block
the conversion of T4 to T3.
particular conversion.
No, it is out.
Yeah, it is not strong enough to cause hypothyroidism. It can only block the T4 to T3 conversion and the some hyperthyroidism symptoms, right? It will not block the production of the thyroid hormone synthesis. Okay. Maternal intake of levothyroxine.
It's also no.
Yes, if it is levothyroxine, we are going to see hyperthyroidism symptoms. Okay. But in this case, we are seeing hypo. Okay.
Yeah, because
so the answer is propyl thiouracil. Okay, because it is going to block the synthesis of thyroid hormone, due to which we are going to see hypothyroidism symptoms.
The last answer was C.
Yeah, the last answer was C. Okay, so this is the last question. Which of the following is the most likely mechanism causing the patient elevated prolactin levels? The patient's TSH is elevated, prolactin is elevated, antithyroid peroxidase antibody is present, the patient thyroxine is low. Okay, symptoms are of prolactinoma and hypothyroidism. So, do you know the relationship between hypothyroidism and
Yes,
prolactinoma?
prolactin. Yes.
Yeah,
That's yes. THS also stimulate each other.
TRH, right?
Yes.
Okay, see this TRH. This is TRH. See this line. This is plus sign on prolactin. So if there is a hypothyroidism, where if the patient has hypothyroidism, what will happen to the TRH?
Increase.
TRH is going to
Decrease.
in
Increase.
hypothyroidism.
Increase in negative feedback. Negative feedback.
Increase.
In hypothyroidism, TRH is going to increase, TSH is going to increase. Our patient has in the primary hypothyroidism we are talking, and our case is of primary. You can clearly see TSH is elevated. It is primary hypothyroidism. Okay, if it is primary hypothyroidism, TRH is going to be high, right? And we can see that if TRH is high, it has a stimulatory effect on the prolactin. Okay. Other than that, you can also see primary and secondary hypothyroidism positive, TRH positive, and TRH positive is going to increase the prolactin. TRH. Okay. TRH increases the prolactin secretion. Okay. So what will be the answer here?
D. Stimulation of lactotro by thyroid releasing hormone.
D.
Yes. It has nothing to do with dopamine. It is not Hashimoto's. It is no TSH mediated. No, TRH mediated, not TSH mediated.
TRH mediated.
Okay, so this is all for today.
Thank you very much.
Thank you.
Thank you.
Thank you.
Don't forget about the
Recordings
QID, Dr.
very
Hussain.
shortly.
Thank you, Dr. Hussain.
Thank you so much.
Thank you.
We will meet tomorrow. There are only, I think, so only 50 questions left of the endocrinology, and after that, endocrinology is finished, and we will start next system. Okay, we have our
Doctor, quick question. Are you
respiratory
sending this?
system is also finished. Okay, after this, we will decide which system we are going to start. Okay.
Dr.
Doc, are
Soon,
you
can we get
sending
the
this?
recording early?
Hmm?
Can we get the recording soon, please?
Okay, I will ask Dr. Ahmed to share the recordings as early as possible. Okay.
Doc, is this being sent in a group chat? Because I don't think the meeting link was sent out yesterday and the recordings. Is there a different group chat?
I don't know whether or not you are in the main group or not. Okay. You can talk to Dr. Ahmed. He will let you know that. So please leave the call immediately, because if you do not leave the call immediately, the recording will not stop. Okay.